40 years in addiction treatment. How many publications, Ian? About 50 or more. Very much at the coalface, the proverbial coalface, for all of that time. Ian McEwan, ladies and gentlemen, Executive Director, Addiction Practitioners Association, Aotearoa-New Zealand.
Kia ora. Kia ora koutou. Kia ora te mihi tuari. I want to acknowledge Ross and the Drug Foundation and NSAD for bringing us all together. Acknowledge the Chair. And a special extension of welcome to Tom, who after today is going on to Auckland to address the annual conference of the addiction treatment sector. So we're very much looking forward to hearing more from you in Auckland in the next couple of days. DAPANZ, it used to be the Drug and Alcohol Practitioners Association, now the Addiction Practitioners Association. And for those of you who aren't familiar with DAPANZ, just a slide about what we do and who we are, so it puts into context a little of the things that I want to say. DAPANZ is unique in that, unlike other professional associations, it's built upon a service role or function rather than by a professional discipline like nursing or social work or counselling or psychology. And I like to think of it more like a craft guild. It brings practitioners together to improve standards, to improve outcomes, to share knowledge and skills and to promote the craft of working in addiction treatment. And DAPANZ registers practitioners according to levels of competency and is about maintaining ethical accountability. It has a membership of over 1,000, which is over 80% of those who are working in the addiction treatment sector. And in my independent and objective view, I like to think of us as a key asset and resource for workforce well-being, working alongside Mataraki, and for the development and maintenance of the sector. And what's the purpose of it all? To support practitioners, to console, I'm adapting a bit here from Doug, to console, to intelligently help, and to strive for relief for people struggling with addiction in their lives. Here's the DAPANZ National Office on the waterfront in Wellington, just so that you know about our administration costs. So our workforce mix, who are we? Well, I'm using figures here from DAPANZ, our own database, and I use the figures from Mataraki surveys done over the years. Well, I'm a practitioner and I'm 56% female, which won't surprise some of you who know me. I'm 21% Maori, 9% Pacific, and 14% migrant. So it'd be interesting in some of the changes that have occurred there. Most of our migrants in our workforce are from South Africa and from the UK. Now, are we an ageing workforce? Gosh, we get into these kinds of discussions all the time, as if it's a surprise, given that we're also an ageing population. But in 1998, I was 42, and now I'm just 47. And I wonder, I just put up some questions there, because I don't know the answers to these, but this is about our workforce. And these are the kinds of questions that will occur to me about our so-called ageing of our workforce. And I wonder if part of it is because of the halving of recovery numbers in our workforce. When I think back to the 1980s, thereabouts, nearly 60% of our workforce were people who'd come through their own recovery. So they were very much the core of what was being provided for people in difficulties. That number now is less than 30%. It's kind of staying a little bit static around that, but it's half what it used to be. Now, anecdotally, because we don't have the figures for this, but when I think back to the 80s, I think of people who went into treatment, recovered, came into the workforce, often in their 30s. And though they may not always have lasted very long, there was a lot of people in that kind of age group, the 30s and 40s, as well as people who are much older as well, who worked for 2 or 3 or 4 years in the addiction workforce. And that seems to be a group that we've really lost out on. And we've lost out on because of the professionalisation of our workforce. We say it's not sufficient to recover. You also need a degree to be able to work in addiction. And so that becomes a barrier to those, especially who are newish in recovery, who are often eager to be able to work with and to help and to support others who've gone through experiences that they've really identified with most recently. And if I think of people that I know, this is the kind of research scientist I am, Tom, most exits seem to occur in the first 3 years of those who come into our workforce. And people who stay after 3 years tend to be in for the long haul. Others will you will know whether this is your experience or not, but it's my observation. I mean, a lot of those exits are, of course, in DHBs with nurses on rotation. But people who stay longer than the 3 years tend to stay, and as you know, we don't retire from our work. We just die in office. So what do? If we look at changes since 2004, counselling, and here I lump under counselling all the kind of work that doesn't fit in the categories below, but 62.7% of us are in that category and trending downwards. And almost the equivalent of a trending upwards is happening in nursing. Now it's 16.7% of the sector. Social work, psychology, medicine, psychiatry have not really changed over the last 7 years. If we look at our tertiary education, which is kind of one of the measures of improvement of our workforce that was set in the initial planning by Mataraki in 2004, we look at our postgraduate qualifications and how they have improved until today. We've got nearly 60% of our sector with a postgrad qualification. And if we're talking about addiction-specific qualifications, that's improved dramatically, partly because the access to addiction treatment learning has expanded a lot in those years, but also because a greater expectation that people working in the sector will also learn their craft. And so about a quarter of our workforce today have specific addiction qualifications at a postgrad level. Now, if we take all our graduates in the sector who have done alcohol and drug studies or a closely applied course of education, like in social work or in nursing or counselling psychology, applied psychology, 71% of our sector today are graduates of an alcohol and drug or closely allied. So it feels like we're growing. There are some real gains that have been made, but there are some areas that are under stress. And it's a bit of a paradox that while there is a growing confidence in the sector, we still find ourselves with some issues. And here I exaggerate. I exaggerate these points to make the point that I want to make. We are anxious. We're anxious about outcome, and I think this was eloquently addressed this morning, particularly by Tom, around there is no cure. And I think there is an anxiety with a lot of with workers in our sector that they are working in an area where there isn't something that will produce a guaranteed outcome. And that often what people are waiting for is the personal epiphany. When I talk to social workers about why they don't come into our sector, what a wonderful sector we are, what great work they could do if they came into addiction treatment, it's not an uncommon response that they say, but you get no good outcomes in your work. And they will use different words, but they say, it doesn't matter what you do, you're waiting for the individual to make that internal decision to change. We're not good at promoting our outcomes. We probably oversold our treatment efficacy years ago, and we're now still living with the consequences of that. And when people look to come into the field, new young workers, that I'm still, that maybe people that I'm supervising, and I'll talk to them about what are the things they really want to, that bring them into the field, and they talk about they want to help people make changes. They want people to become well, to overcome these problems. And they quickly become anxious when their first experiences of working with clients doesn't match that. I'll come on a little bit later to another aspect of that. I think sometimes we get a bit depressed. And depression is, and here I'm talking about south of Auckland, are in some of the DHB attitudes to our sector, as we see a trend of alcohol and drug positions when they're falling vacant in the DHBs are not being replaced with alcohol and drug practitioners, but are being replaced by often junior nurses on rotation who have no training in alcohol and drug, will get some training on site, and then will move on after 2 or 3 years. For the rest of us who work in addiction, what is that saying about the way that a DHB values the kind of expertise or experience that we bring to our role? So the issues of being a valued workforce have always been with us, partly as a result of the stigma that people experience, not only as clients, but even of those who work in the sector. But the sense of stigma that we get from fellow professionals. And funding. Enough has been said about funding. It's a retracting funding environment, and our sector is often at the bottom of that. And that leads into my well-developed paranoia about the opportunities for training. And again, particularly with DHBs, as they're moving more towards a workforce that is registered under the HPCA Act, priorities for training clearly go to them. So that some of our non-registered workforce, registered as with the HPCA Act, are finding access to training becoming more and more difficult. And recruitment, I'll leave that just for the moment. Recruitment is another area that people are experiencing, managers are experiencing difficulty. And then we've got our uncertain friends. Now, we've talked about primary care, we've talked about mental health, and I don't think really there's anybody in our sector who wouldn't say that these are areas that we need to get into, that it needs to be an integrated experience for the client. But in terms of workforce, uneasy bedmates. We celebrated in the 50s when we came out of mental health. We felt that we really started to develop and be able to give a very different experience to our clients for having come out of mental health. And now we're going right back into mental health, at least in the DHB sector. And what's happened is we've seen a whole removal, south of Auckland, a whole removal of alcohol and drug leadership and alcohol and drug management. And it's been replaced by mental health management. Now that in itself isn't wrong, but mental health has a different culture, has a different set of priorities, has a different way of understanding and addressing the issues that our clients present, and a different management system, and the things that they particularly value is the mental health nursing and the risk management safety that an HPCA Act presents. So we want to be with them. We want to have a good night's sleep with them on either side of us in the bed, but mental health feels like a huge person I'm trying to sleep with, and primary care a reluctant person who keeps pushing to the edge of the bed because they don't really want to know us. They don't want our clients in their surgeries. The Maturaki survey of service managers in 2008, stable workforce, because we're all 47, but a specialised addiction qualified staff really hard to recruit. It's not a popular area of work. And again, it comes back, I think, to that confidence about what is it we really do in treatment. And the training and professional opportunities for our sector are shrinking, and again, make that really a difficult basis on which to recruit the staff that you want. Now, I don't want to bag him, but I couldn't resist this. In a conference just 2 weeks ago, the Registrar of the Medical Council treatment of addictions lie with doctors and the therapeutic professions, that is nurses, which dismissed 80% of the workforce. I didn't say anything. There is a need for a specialised addiction treatment workforce. And junior nurses on rotation are not going to do this alone. Experienced nurses and counsellors, experienced psychologists, social workers are critical to a multidisciplinary approach. Because addiction so complicates other health disorders that people need to be treated in an integral way that must involve family and whānau and the human environment of the person being treated. And no one discipline holds all these aces. High quality counselling, social work and behavioural health specialism is needed equally alongside medicine. But to achieve that high quality counselling and social work particularly, their practitioners, we are going to have to know more about medicine, about how the brain works and about genetics they do now, as you're pointing out this morning. We will need to pick up higher level skills in working with families and potential therapeutic allies in the environment of the client, working with therapeutic groups and working with mental illness. Now at DAPANZ we have a renewal of registration process annually based upon continuing education, and particularly upon an instrument called the Reflective Practice Journal, in which people write up particular pieces of work they've done that have been illustrative to them, helpful in their practice. And I can tell you from that that not every counsellor is a good counsellor. And I can tell you from that some counsellors are extraordinarily good. But if good counselling is an essential ingredient of treatment, then we must invest more in good education and continuing training of a higher standard than relying on the lolly shop of half-day workshops, one-day workshops. We mustn't take new graduates, as we're often doing at the moment, whose training has been counselling focused, and throwing them into groups of at times difficult and ambivalent, resistant clients and telling them to just do it. A truly multidisciplinary team model, whether it be in the community, in criminal justice, residential services, community, wherever, primary care, mental health, is a fundamentally best model for the delivery of the treatment of addiction. And we're for our recovery workforce. I've mentioned the history of it, our treatment really started with the recovery movement. And it was such an important part of our workforce until we decided to become professional and wanted to be like psychologists and wanted to sit in our rooms and see clients one at a time for an hour. And their proportion of our workforce shrunk. Though recently, interestingly, there has been a growth in peer support thinking and new initiatives in peer support work, and to acknowledge too those services who have used peer support all through the years. But it's still it's not a prominent feature of our treatment delivery. And paradoxically, this unique development of using people in recovery as part of a treatment which started with addiction is now being picked up by other areas in general medical care about the importance of peer experience and people trying to make changes in their life at the same time as we're still minimising it. We need to develop respectful relations with mental health and with primary care. And some of this is going to be around the way that we provide treatment. It was mentioned, I think, Tom, you mentioned it earlier, about the shortage of the experience of treatment that we offer people in terms of the way that addiction has affected their whole life. And still, a number of our services are contracted to provide 8 sessions of treatment. And in an outpatient setting, 8 sessions of treatment is 8 hours of treatment. And when somebody's developed 10 to 15 years of addiction experience in their life, and we're going to offer them 8 hours, and then off they go, and we sell, if not deliberately, the message is that we have effected a cure, and that's what we say to the individual and to their families. And when the experience is different, it undermines the whole integrity of treatment. And experientially, we know that 8 hours for people who are more towards the top of that pyramid is just not going to be effective. And yet too often we're still delivering this same kind of treatment. And I think it's another reason why it's very difficult to attract people into our field. Maybe they feel more intuitively than we do that sometimes the treatments we offer are obviously not effective. We need not be frightened by the evidence. We have a resistance in this country to manualised treatment, and there have been many an effort made to encourage our workforce to take up motivational enhancement therapy or a pure form of motivational interviewing, or to do CBT and to see a whole CBT program right through with clients, to do community reinforcement approach. A number of manualised treatments have been introduced to our workforce, and we get terribly excited and embrace them, and then reject them. And we pick up the spirit of it somewhat, and try and incorporate the spirit of these things into the work that we do. But there is a resistance to it. And still what often seems to be provided, and this fuels, I think, a little of the despair around outcome, what fuels it is that we still give great emphasis to the building of rapport and to the engagement process. There's a lot of teaching that we provide around the comprehensive assessment and formulation that results from that, so that you know when you're working with the client on what needs to happen, and this is the treatment program that should follow. And in my experience with a lot of the newer workers, and not just so new workers, is that's the point where it stops, and people become very unsure of what to do next. This is the problem. Here we've got it all boxed up nicely for you, but let's just wait for the epiphany to occur. And so we get a bit frightened, I think, about the notion of evidence base, and the evidence base that gets presented around the treatment that we do know that is effective, and it's about trying to match that effectiveness with the right kind of client, is still a tension with the really important thing that I have to offer is me as an individual, and it's really about good engagement and good rapport. I'd like to see the HPCA Act. This is the Health Practitioners Competence Assurance Act, which is in this country for the safety of the public, particularly around anything that's intrusively done to the patient. So it's a public protection mechanism for it, and it's managed by registration bodies around professions. Drug and addiction practitioners are not a registered body, and so some of the problems I've been talking about as a result of the HPCA Act being used. For example, we've got addiction practitioners working in DHBs with postgrad qualifications in addiction who have to have their work signed off by a junior nurse on rotation because she comes in under the HPCA Act, or he, and the addiction practitioner doesn't. And though one can see that the whole reason for that is the risk-aversive nature of the management of that service, the message it actually sends to the practitioner is that the value we hold you in is incredibly low. And of course it's so unnecessary because risk management doesn't rely totally on the HPCA Act. So I'd love to see the HPCA Act used as intended, as a way to protect the public, but not as a way to prevent our workforce, the non-registered workforce, of being able to operate within its competency. Addiction is everybody's business, and addiction treatment, as I think somebody put up on a slide, or in one of the headings of the books, addiction treatment is everybody's business. We've got a very committed addiction workforce who really want to do well and who work very hard, and increasingly, as you see from those earlier slides, are learning and studying, and 400 of them are going to come along to the next 2 days in Auckland and to hear people like Tom. 400, that's a third of the entire workforce will come to the conference. I suspect there aren't many other workforces that would turn up at that kind of proportion for an annual to learn. And there's a real hunger for learning in our force, and it's becoming increasingly an experienced and sophisticated workforce, but it is a fragile workforce, and it needs protecting. Thank you.